Hello, everyone, and welcome. I'm Silvana Di Gregorio, and I'm the Research Director of QSR International, who are the developers of the NVivo software. And QSR is very pleased to sponsor this webinar with the International Institute for Qualitative Methodology. So I'm going to be actually facilitating it. Professor Olson isn't here at the moment. So without any further ado, I would like to introduce our first speaker. So we have two speakers, just to say we have two speakers today. And I think what we'll do is take questions, maybe a few questions in between after the first speaker, but really to have most of the questions after the second speaker, just for time purposes. Right. So our first speaker is Dr. Miriam Kabi, who's a postdoctoral associate in the Nuffield Department of Population Health Sciences in the University of Oxford. So over to you.
All right, great. Thank you so much for the invite to speak today and for this nice introduction, and everyone for attending. I hope you all can hear me okay. So today I'll be talking to you about a study that we did on lifestyle treatment recommendations by adolescents with obesity to inform policy and program decisions. So this is going to be all about teenagers. So for those of you who do have teenagers, I'm sorry you have to sit through a presentation all about teenagers too. So to start off, giving just a brief background on obesity. So we know obesity in adolescents is quite difficult to manage successfully, particularly considering all the behavioral, biological, and psychosocial changes that they undergo. And compared to children, adolescents tend to show higher attrition levels from weight management programs once they do enroll, and to also be less successful, in fact, in managing their weight. And there was a recent Cochrane systematic review that also showed modest effects on BMI that resulted from lifestyle and behavioral changes alone. And either way, they tend to be not durable. Now, from a policy making perspective, we know that there's typically, you could say, increased legitimacy and feasibility and justifiability of policy-making processes when we involve intervention recipients in the design versus going with more traditional top-down methods, which we tend to see quite often, especially with adolescents. Now, what's important to note here is that adolescents, again, because they may often be excluded from the process of designing lifestyle interventions that could inform these policy-making processes, this minimizes their concerns, needs, preferences, and priorities, and may actually explain why they're a challenging group to engage in obesity management interventions. So this underscores the importance of identifying recommendations as reported by adolescents with obesity themselves, since it could be a decisive factor in both the success and the uptake of healthy lifestyle interventions. So this research was qualitative, cross-language, and patient-oriented. What this means, so if we look at the cross-language component of this study, this is referring to research involving 2 or more languages, and this is typically done to bridge the gap between language and culture. So we conducted our study in Canada's 2 official languages, which are English and French, and this is to account for cultural diversity and better represent Canada's population of both Anglophone and Francophone adolescents with obesity. And the patient-oriented research component, this is actually growing in momentum recently, which refers to 3 principles for the most part. One is that the research engages patients as partners versus simply as participants in the research. And the research focuses on patient-identified priorities, and ultimately it aims to improve healthcare systems and practices. And this does add quite a bit of work to the research, and there's a lot of I don't want to say criticisms about patient-oriented research and its effectiveness. But we always say that regardless of any direct changes or improvements to the health outcomes of patients, it remains of intrinsic value, since we're capturing the experiences and priorities of our partners and our end users to hopefully integrate that into care. So we used purposeful sampling to recruit 13 to 17-year-olds. That's who we defined as adolescents. And they had to have a BMI of above or equal to the 85th percentile, so having either overweight or obesity. And we conducted this process in 2 multidisciplinary weight management clinics in Edmonton and Ottawa to ensure we had both the Anglophone and Francophone representation. And then adolescents participated in individual, in-person, semi-structured interviews in either English or French, and following the based on our experience and data. The data itself was transcribed verbatim by a professional transcription agency. We used NVivo, the part that's fitting for this talk, to manage the data, and then we analyzed it using both qualitative and quantitative manifest and latent content analysis. So just to give a brief, behind the scenes of what we did with the coding, is that we developed a coding tree which included familiarizing ourselves, so 2 independent reviewers, with each interview as the unit of analysis. And this was followed by iterative development and refinement of codes that were identified, and subsequently sorting and abstracting text into data developed categories. And of course, we had reflexive team discussions throughout the process. For the translation component, so translation tends to be a very gray area when it comes to capturing meaning and ensuring that there's conceptual equivalence. So we definitely ensured that we looked at the literature beforehand, and we've undertook recommended processes for translation and cross-language studies, and used several verification strategies as well to enhance the rigor of the study. And this included investigator responsiveness, methodological coherence, sampling adequacy, and along those lines. So this here is just an excerpt from the publication, and I just wanted to show you, I don't know if you can see my mouse on the screen, just how we had categories which were then divided into subcategories, and then key messages per subcategory. And what we came out here with data from 19 adolescents who were interviewed. This was enough for us to ensure data saturation, which is when no new categories or themes emerged. And so we came out with 5 different categories. And I'll just go very briefly into these, being mindful of time. So the first is to establish parental support, but within limits, and this was identified by 15 of the 19 adolescents. And just to note here, while we did quantify the contents analysis, it doesn't necessarily imply that one category is more important than the other. It just kind of shows the distribution that we saw in our sample. So I have some quotes here per category, and here for establishing parental support, adolescents essentially perceive their parents as key players in helping them make lifestyle changes. So they recommended less family conflict and for their parents to actively support their attempts in a healthier lifestyle when it comes to different areas, from nutrition to activity to sleep. And even though adolescents described a value to parental support, they weren't necessarily keen on authoritarian style parenting. So that is one thing that came out for that category. The next one, which is to improve accessibility and availability of quote-unquote healthy foods. So here, most adolescents recommended lowering the cost of healthy foods to help them make healthier choices more often, particularly when they were purchasing these foods. And some went further to recommend that healthy foods such as healthy foods not be taxed. And in the school setting, adolescents shared that practical classes such as home economics, which tend to be dwindling down from the curriculum, it seems, nowadays, they found value in those kinds of classes that were focused on healthy eating to help them build their knowledge and skills. And then lastly, several participants commented on how supermarkets tended to promote junk food in numerous aisles or in attractive places, like near the cash registers. And I don't blame anyone who falls into that trap, because they're right there when you go to the cash register. So that is one thing that they picked up on. And then in the school setting, again, the unhealthy food comments pertain to the cafeteria for the most part, and how there wasn't a balance in what was being offered. The third category we have is, so here you can see one of the quotes, actually. I'll read it to you. So my high school has a foods class, and it's almost like you don't have a chance to take it. As soon as it opens, you're placed on a waiting list to enroll in the class. Maybe they should have a second class. So limiting deceptive practices in food marketing. So here, adolescents commented on the extent to which digital and commercial culture almost saturated their lives, and really highlighted the need to change the digital and commercial food environment to facilitate dietary changes. So specifically, they commented on the influential role of food advertisements, including the digital editing of foods and fast food advertisements to make them look more appealing. And they also picked up on other tactics used in advertising, such as airing a higher proportion of unhealthy to healthy food commercials on TV and social media sites. So their recommendations included airing more commercials of healthy foods and banning commercials of unhealthy foods, which I know is a work in progress in some areas. And second last is improving accessibility and availability of varied physical activity opportunities. So here, adolescents recommended physical activity opportunities to be more accessible, and they cited issues related to cost, distance, knowledge promotion efforts. And the cost did come up here as well. So adolescents shared quite strong feelings about improving the affordability of some programs that were offered, and even exercise equipment. I believe I have a quote for that here. And in terms of the in the school setting, there was a specific recommendation, actually, it seemed, where there were two classes that were offered for physical activity. One was focused more on fitness, and the other was more on sports, and they recommended to mix these two together to provide more of a variety for adolescents who are taking those classes. And in the community setting, ensuring that these programs that were offered were tailored to different ages, religions, and interests, because oftentimes it was noted that that was not the case, and a lot of what was offered was not really geared towards adolescents, and it was more focused on adults or younger children. And lastly, my favorite, it's adopting a later school start time. So when discussing sleep, adolescents described favoring later school start times to better match their sleep schedules. And they commented actually on how a lack of sleep may have a negative influence on their other lifestyle habits. So in particular, making unhealthy dietary and physical activity choices, if they're feeling tired as a result of waking up earlier. So for those where this is applicable, they recommended to delay school start times till 9 a.m. And so, in conclusion, our findings indicated that adolescents' recommendations are quite unique to that population, and if they are not being questioned on their values or not thought on their values and their preferences, these may not be adequately reflected in current health promoting lifestyle initiatives and interventions. So it's important for stakeholders to consult and involve adolescents in that process to be more responsive of their needs. Now, how much time do I have? So I can happily skip over limitations. So I believe I have 2 minutes. So most participating adolescents were of Caucasian origin. With that said, we did capitalize on transferability of our findings by including both Anglophone and Francophone participants from 2 geographically diverse provinces in Canada. And then just like with any the qualitative nature of our study, adolescents may have been limited in their ability to articulate some of their experiences. And a lot of times, a lot of behavior change theories comment on the challenges in articulating macro level as compared to micro level factors that may be influencing a person's behavior and decisions. So to minimize these possibilities, we just made sure that we provided adolescents with numerous probes and opportunities to refine or expand on their answers at multiple time points during the interview. And the last thing I want to mention is that this study was a part of a larger study, which was my thesis actually. And so this study, essentially the output was developing a theory-driven, patient-centered clinical tool that tailored for adolescents with obesity that they could use to help empower them in being engaged in their own care and making healthy lifestyle changes. And this was developed with adolescents, by adolescents, and certainly acknowledges the recommendations that were provided in the study as well. Shameless promo, as always, I just have to throw that in there. These are available online for anyone who is interested, and there's another copy that is tailored towards parents. So this is a complimentary version just for adolescents. And of course, none of this would have been possible at all without the amazing encouragement and support provided by everyone who was involved in the research, from peers and collaborators to the generous funders that you see here on the screen. And with that, I would like to thank you all for joining us today. And if anyone has questions, you're free to email me or ask shortly.
Thank you, Miriam. Can I just ask people that you can write your questions down in the question box that you'll see in the GoTo webinar panel there. So we might take a couple of questions before we move on to our next speaker. But I just want to say that Professor Karen Olson is now with us. So she will sort of take over in terms of facilitating the questions. So over to you, Karen. We don't actually have any questions yet, so please do write your questions down. Yes, I mean there's one question that's just come up here that I was going to ask, which is, can you say more about the integration strategy for the qualitative and quantitative data, particularly since you use both qualitative and quantitative content analysis? Quite interesting.
Yeah, certainly. So the way we approach the analysis is we looked at our data and what they were telling us before we actually looked at quantifying these. We approached this more from an inductive point of view, where we just followed what the data was telling us and came up with the different categories and subcategories. And then from there, we went back into the data to see how many adolescents actually reported on these different categories. And the reason we went with categories versus subcategories is because if we were to go the latter route, then that will essentially be too sparse. So the numbers that you see reflect the broader kind of recommendation versus the specific recommendations that were shared with us. But I think at the end of the day, it's still important to see, knowing that we achieved data saturation from these 19 adolescents, it's important to see how many were actually interested in and had suggestions and feedback in particular areas. I hope this answers the question.
Right. I'll just take one more question before we move on. There's one question here about trustworthiness. Can you let us know more about the trustworthiness techniques that you may have used in the study?
So for the trustworthiness component, this included, investigator responsiveness is one of the factors there, and it's a lot of it is about being reflexive and ensuring that we're acknowledging our own biases as insiders slash outsiders of the study. And so by documenting field notes, which were also actually integrated in managing the data and the analysis, we were able to separate ourselves as much as we could from the data, and then ensuring, having those team discussions and those reflections, and integrating more than one researcher to conduct the analyses, to kind of have those back and forth, I think was really important to ensure that we're not kind of just doing things on our own, and we are just proceeding with what the data says. Does that answer the question? Hello?
Hello?
Oh, I can hear you now. Hello?
It's Karin here. I'm just looking through the questions to see what comes next. We're still, I think that was a great answer to the trustworthiness question. I think we've come to the end of the list of questions. Are there any others out there that people would like to know about? Oh, I see one here, Miriam. Has there been any similar research in other countries, and if so, are the results similar?
That's an interesting question, actually, and to my knowledge, there wasn't, which gave more of a rationale to conduct the study starting in Canada. But if anyone is aware of any other studies, I'd be more than happy to read them over.
Okay, thank you. And also, did you consider doing interviews with professionals working with young people to balance the young people's perspectives?
We actually did do that, and that is that's a different presentation.
Okay, so we'll just go back to that.
Data.
Yeah. So we have another question here. Biggest barriers regarding using NVivo?
Ooh. I would say the biggest barrier is that I realize when my computer goes on sleep mode, it does not save any of the coding that I had done for the past week. So I have to start over again. Other than that, I mean, I feel like once you get the hang of NVivo, it's really a fantastic resource to manage the data and be able to group different parts of the transcript that you want to combine together and be able to look at that after. But any other barriers other than that don't really come to mind.
So the take-home message is save as you go, right?
Yeah, and exit NVivo. I don't know if it was just me and the version I was using, but that's what happened.
Okay. Any other questions? Well, thank you very much, Miriam. That was a great talk. I'll look forward to listening to the recording.
Thank you. It was a pleasure.
We're going to go now to our second presentation from Mamoda Burgum. Mamoda is a senior consultant at the Strategy Unit, hosted by Midlands and Lancashire Commissioning Support Unit. The Strategy Unit is an NHS consultancy which uses applied intelligence and innovation to address complex challenges health and care services face. Mamoda works in a multidisciplinary team, mainly supporting transformational change in health and social care systems, using mixed methods focusing on high-quality research and evaluation with a special interest in qualitative evaluation. She studied biomedical science and public health and has worked in the NHS research setting in a social marketing research sector for over 10 years. She is passionate about including experiences of people in transforming healthcare, care and well-being services, and her interests include public health, community development, and addressing wider determinants of health and well-being. Please join me in welcoming Mamoda.
Thank you for that lovely introduction there, Karen. I didn't quite expect it, didn't quite prepare for that. But just to kind of carry on from what Miriam was saying about the save as you go, completely agree. We've had team members who have had massive challenges with that. So I second that tip there, and I think it's the top tip of this session. So definitely note that one down, everybody. So going on to what I'm presenting about today. So we're going to be looking at an evaluation that we recently completed of a large UK health systems winter plan. You'll notice some of the language is generic, mainly because it's a very recent piece of work, so it's currently just being reviewed. So not all the details could be shared, but it's a really good project in terms of multi-methods and the use of NVivo. So it was one that I wanted to share today. So just before I sort of get into the thick of the evaluation itself, I thought it'd be a good idea just to do some scene setting in terms of how we operate as an organization, which might be able to, which kind of relates to why we approach the evaluation in the way we did. So the strategy unit itself is hosted by a Midlands and Lancashire Commissioning Support Unit, who basically support NHS colleagues and organisations to use evidence and innovation and applied intelligence to kind of address really complex challenges in the healthcare system. And we do this with kind of supporting their thinking and navigating through quite a changing and challenging territory actually at the moment. So that's where we fit in. And this little diagram here is basically just to kind of describe where we see ourselves. So we have this whole world of academics where their role is predominantly in research, in getting the right method, and it's really important to have that rigorous approach that they take. And then on the other sort of side, you've got the management consultancies, which are sort of concerned more about the practical elements of decision making. And we, I guess, sit somewhere in this intersection, where as a NHS organisation, we sort of strive to be like the management consultancies, and be really rapid and relevant, but like the academics, we also want our approaches to be rigorous. So that's where we sort of see ourselves at the moment. And because we are in the NHS, we really work for the NHS mainly, and our staff and our employees all are animated by the values of the NHS. The unit itself works for a whole range of organisations, from integrated care systems, commissioning groups, NHS England, which is the national body, and various organisations in the third sector, which is all to do with community and charities. So some of this language might not be familiar to all the international audience that we've got with us today. So that's more for the UK audience, but it's mainly in commissioning services and designing services. So in terms of our sort of approach and how we work, I guess we take a pragmatic approach. So in an evaluation like this, there's obviously a systematic approach that we try to implement, but it's all about bringing these elements together to work best for our clients and customers in the NHS. So we combine our quantitative knowledge. So we've got a massive analytics unit here who work very cleverly with lots of data sets that we have available within the NHS. Then we've also got an evidence review team, and then we've got a big element of our applied qualitative team who we all work together to kind of work on either system improvement or strategic consultancy, which is all about decision making within the service. And that could be to address any problem, whether it's to diagnose a problem or to develop solutions or to support the delivery of these solutions. So we've kind of tried to take a very holistic approach, and that's the approach we've tried to adopt in this evaluation. Just before I sort of delve into the evaluation, just to touch upon our team. So we're a team of 35, but we all had very minimal experience of NVivo. So just to relate it back to the audience of interest in NVivo here, we were mostly kind of self-taught. We had a couple of bespoke sessions in terms of how we might use NVivo for the types of work we do, and we've sort of just been building on that over the last couple of years. And we started with very simple sort of use in terms of data management, and I think we've kind of excelled at where we're at the moment, and see lots of potential for it going forward. So going into the evaluation now. So this was an evaluation of a really big health system in the NHS in England. And what we were looking at was their winter plan. So we started off with this theory of change where if there's a sort of integrated approach and a single winter plan for the whole system, by system we mean all the partners in that system. So you've got hospitals, you've got primary care, you've got community services, social care. So we said if there's an integrated approach there, then there can be an operational alignment in delivering the winter plan. And then if the alignment is there, then delivering the winter plan, you can do that with better management of patient flow throughout the system. And then if that's there, then the hope is that then there are improvements in system performance as a whole. So just as I mentioned earlier, we took a sort of mixed methods approach to the evaluation based on this theory of change set out here. And some of the objectives of the evaluation were to sort of describe the experiences of the system and operational leads who are managing the urgent care services, and then also within that to describe the experiences of people who were utilising those services. So that includes staff members who are delivering the service and patients, and then by that assess the performance of the system as a whole by focusing on specific initiatives that this particular system was delivering, and that was looking then at outcomes such as hospital admissions, improved patient flow, and discharge. So there were some of the things we were hoping to look at across the different methods. So to touch on why, so there's a real lack of national understanding of the effectiveness of winter planning. There's a lot of work to be done nationally across the NHS in making a sufficient running service over that period of time. So what we really focus on with the customers that we work with is using a very informed approach. So rather than systems learning from other systems, the biggest impact we've found and seen is where systems try to learn from themselves. So we're really supportive of this self-improving system, and we wanted to kind of support that here. So what we did was we had a few methods that I mentioned, so which were included the rapid evidence review, which explored underpinning the evidence base for sort of some of the initiatives that we were looking at and this system currently delivered, and that was to look at how does that meet the demand for different seasonal changes. So obviously here for winter. We also employed a few qualitative studies, and this was to explore experiences. So for this we did meeting observations, assurance call observations on a daily basis, and senior staff interviews along with patient interviews. Within that, we also did a document appraisal of all the sort of local documentation, that was sort of meeting notes, plans, policies, that sort of thing, from the different organisations involved. And then one of the bigger chunks of the project was a quantitative analysis, which focused on assessing the aspects of 5 priority initiatives that the system was delivering. So within that, what I'll be focusing on in the next few slides is mainly the qualitative studies and how we use sort of NVivo to manage that. But basically, all these findings were triangulated across so that we can make some really key recommendations for this system that could be applied to very similar sort of systems across the NHS and wider, and organisations as well. So what we did, I guess we just threw everything in. So beginning with sort of interviews, we had a whole range of transcripts from senior stakeholders and the patient interviews that we did. We had all our sort of notes from the observations that we did, and there were a lot of notes, masses and masses of notes. So just going back to previous years, you know, we had like 10 meeting observations, so they had a series of notes to them, and then we did daily observations on system resilience schools, and we had 84 of those, along with the staff and patient interviews that we did. So after throwing it all into NVivo, I guess we used NVivo for 2 things really, to help us manage the data that was, because there was just masses of it, and I wouldn't know where to start spreading it out across my desk, but the whole team of us worked on this actually. So some of the findings that were coming out of NVivo we used to kind of inform our quantitative analysis. So to maybe query what things were coming out, what people were talking about, to then test that whether that had an impact on the outcomes that I mentioned earlier in terms of emergency admissions, length of stay, and discharge. But the rest of the data, and the masses of it, one of my colleagues spent hours and hours and days of their time sort of coding and going through it. But to go on to our approach to the analysis itself, we took a deductive approach because we had this theory of change that we started with. So the theory of change, we looked at what we already developed a framework from that, which was an evidence-derived framework based on some work on organizational culture and healthcare systems done by Braithwaite et al. And Russell and Hugh, which I'll put in reference for it in the slides that if we share them. So the framework itself had these 3 broad kind of concepts we're looking at. So we're looking at people, process, and place. And I'll go into a bit more detail in that in the next slide. But really the approach when we had this much data going into NVivo, we looked at sort of coding it to our main framework, which I mentioned was these 3 main concepts. And the 3 of them were split by, so people was all about the perspectives and behaviors of the system and the operational leads that were delivering the service. The process was much more to do with the specific initiatives. So there were 5 of those that we were coding to. And then the place was all about the provider organizations that were delivering the care across the system. So that was our main framework. We then went on to use NVivo to support a thematic analysis. So this was kind of drawing out the themes that were coming out and that we were noticing, and then exploring those patterns and relationships to kind of see what the connections were. And then finally, we sort of synthesized that using sort of queries in NVivo, and we used kind of visuals to sort of mold our thinking. Within this, throughout this whole process, there was a team of us who were analyzing it, involved in different elements. So we met quite frequently to test our thinking and to query the data that was already in NVivo, which we did. So just to kind of give you a pictorial of our framework, so the people covered these elements, so things like organizational context, leadership, relationships, system delivery, performance, and then the process, as I mentioned earlier, was the sort of 5 key initiatives, and a few of those I'll go into shortly. And then the place was all about the different providers of the service. So you had like social care, the hospitals, the community trusts. And the idea was really from this to identify what worked well when planning for winter. What does winter planning actually mean for the system? How is winter planning sort of managed, delivered, and experienced, and what are the outcomes of the planning? So this slide set could have been a lot longer, and this webinar would have been a lot longer, but we've decided to sort of focus on the qual elements and the triangulation that we did. So missing out a chunk of the sort of detailed findings, I'll try and summarize them here. Some of the tools that I mentioned that we used in NVivo included sort of mind maps. So this wasn't something we had used before, but we found this really useful here. So in our report, it consists of a summarized version of all the findings, and it also goes into talking about breakdown between it breaks it down into sort of the initiatives that we talked about, and then also across the sort of themes that were coming out under things like relationships and leadership and system delivery. So within this, the mind mapping that we use it initially to sort of look at the factors that we need to consider that were coming out. So this was our theming of it. And then to create summaries of each of those themes. And then from the patient interviews specifically, we use them to create patient journeys from what the patients were telling us, because that was transcribed. It was really easy to do that using a mind mapping process. And then again with the patient narratives as well, because as with interviews, you can kind of touch on lots of different areas. You can kind of jump back and forth from a story. So to try and bring that together and put that into a coherent sort of order and form that would be impactful and powerful for the people that would be reading this report was really important. So there were some of the things we did, but that gave us the ability to take a really holistic approach here. And I guess that was the benefit of using NVivo for such mass data. Just to look at some of the key findings, so I've not included all the initiatives here, but some of the key initiatives we looked at were neighbourhood services, frailty services, and urgent treatment centre. So as you can see from this, we sort of triangulated across the different methods that we used and what came out of them, and then made recommendations based on those. So for instance, with the neighbourhood services, we knew that there was a cohort of 65 plus who were less frail, but had a reduced admission activity over the winter. And then the experience of patients was slightly different in that they actually looked favourably upon the service and thought it was really helpful, which coincides with the sort of quantitative findings that we had. Which kind of aligned with the evidence base that was suggesting that that an integrated way of working with neighbourhood services. We gave patients a better care and a better experience, which was kind of I guess reflected by professionals' views, and from that we sort of suggested that as long as you sort of remove the barriers of neighbourhood working between the different sectors and services and organisations, then you kind of improve staff experiences and you manage their expectations, and that they're able to then manage the patients that they're working for and with. And similarly with the frailty service, we kind of looked at the frail elderly patients who were admitted to A&E, but we found that they were too complex to be actually considered for the service, and this was kind of reflected by the patient's experience in that they weren't really put to the service. They were kind of going through A&E more, and their experience of that wasn't great. And then streaming that to where evidence-based was talking about actually if you have these pathways that are shared and multi-organisational, then that's where the real benefit is. And so our recommendation there was to review the criteria for the service. For the urgent treatment centre, we couldn't do the evaluation because there are too few users of the service from a quantitative perspective. But speaking to sort of patients and professionals about it, that reflected that there was a lack of I guess engagement with the service because people didn't know about it. But from what we found with the evidence base is that it could potentially reduce emergency activity, but there needs to be a very well established model, which led us to make the recommendation to co-design the service with those who are involved and who it concerns and who would be using it, and to allow sufficient time for that to embed. From that, we made some key recommendations across design, culture, and measurement. So for this design, we looked at, we kind of said, every system is perfectly designed to get the results it gets. So what you need to do that is co-design. You need to address your local needs, and with that, look at equitable access to care so that it's available to those who need it when they need it. And we looked at focusing initiatives as opposed to having a whole range of them. Focus a few for those that for your population needs, basically. And the second kind of area looking at culture was all about strategy. So as long as you sort of empower the stakeholders in the system and they can take collective ownership and accountability of the initiatives that are being delivered, then the morale will increase, and it's all about developing sort of trust between the workforce as a whole. And then finally, what gets measured is what gets improved from what we've found in various systems that we've worked in. So it's working with regulators as opposed to for them to better the system, and taking a systematic approach to do that as opposed to a sort of ad hoc sporadic one that we've seen in some places. So overall, as long as you involve people that are relevant, that processes are clear and robust, and that you have designated spaces to deliver the services, then you should be able to have an effective implementation of the services in urgent care. So finally, we kind of just said, as long as the system leaders own the winter plan and remove the barriers that exist between those who are operating and delivering the service, then operational leads can be engaged and empower their frontline staff to deliver this multi-agency working. And the frontline staff can sort of prioritize delivery using co-design, and then with that, the hope is that patients and professionals have a good experience and has a positive effect on the system performance as a whole. So I think I've run a little bit over, but that's the evaluation. And just to kind of sum up our experience in terms of using NVivo, I think we're looking now to use it for purposes of cross-organisational working and look at its functionality in terms of reporting, because a lot of that was still manual. But that's us.
Thank you so much. That was fascinating. Any questions?
Oh, yeah.
I don't see any yet, Mamoda. I think people are probably writing, so I'll kick off with one. Could you talk a little bit about the NVivo training that you received, if any, or did you figure it out yourselves? Or I wasn't quite sure about that point.
So we did actually have, so a few of us have used it previously in our studies a lifetime ago. So when we came to use it here, most of the team hadn't used it before. So we did a getting started module online, which was, I think, like a couple of hours. And then we brought in a bespoke trainer. So we had two. So we had somebody who was recommended by QSR, and then we managed to find someone in academia who was able to tailor the training and the use of NVivo to how we use it and how we might apply it to some of the work we do, which goes kind of wider and might be slightly different to the traditional use of it in academia.
Thank you very much.
Oh yeah? I don't know. I've never touched anything. You just keep it right.
Certainly, I've studied it for my PhD.
So I'm not seeing.
Corinne, well, we have two other questions here. If you can't see them, I can certainly ask.
Sure.
So one question is, could you explain how the participants were engaged in the interpretation and the sharing of the findings?
So in terms of like the staff participants and the patient participants, the patients, when we kind of spoke to them, we kind of said their kind of narratives will be shared with them, and they'll be able to kind of sense check them along with us, but they were all sort of fine with that. And then the other element was with the staff. Most of the staff that we interviewed were obviously on the senior leadership of this, so they would have seen this report. And I guess our experience of this evaluation has really made us think about giving to the participants of any sort of evaluation work we do, or any of the projects we do really, and that this project really helped open our eyes to that. And I guess it was really important for them to understand how this would influence change in their system that they were using. So at the moment, it's just going through the sort of review process with the senior leaders that commissioned this piece of work. But the intention is to try and share the findings wider so that it can have a greater impact on the system.
Great. And then I have another question. When you say deductive analysis, do you mean you sifted through all the coded data to see how it correlated with the existing framework that you'd come across?
Yeah, so we started with the framework because we had this theory of change and we had worked on similar sort of systems before. We already knew what our framework was going to be, but it just ended up being threefold because we had the people sort of, if you say there was three frameworks, the people framework was from evidence-based work that we had done before on sort of systems and culture in healthcare, and then the process one came from the client and the system in terms of what initiatives they were delivering, as did the sort of place, because it was a set group of providers. But we started with that framework and then coded everything to it. So we had to triple code in essence for some things. But then we were able to query the data to check our understanding, and that's where the mind mapping helped us check whether our sort of theory was correct and whether we had employed the right framework to do that.
Okay.
Hi, it's Karen here. Could I just jump in here and ask a related clarification point?
Mm-hmm. Yeah.
Typically, when we teach qualitative research, we say that people should develop the framework from the data rather than start with an existing framework. But I think what you're pointing out is, from a pragmatic point of view, in a healthcare system where you're trying to move quickly and solve problems, that doesn't always work. So you had to use a framework that you had made previously. Would that be accurate?
Yeah, so from our experience, and this was all evidence-based, so from our experience, we had already seen what systems need in place and what, I guess, what elements or what what are the sort of different concepts that they had to consider when building a system, an efficient system. So we based it on that. But what the evaluation allowed us to do was figure out within those elements what works well for them and what needs to exist within them to enable them to function as best as they can. And that's the bit we were doing, whereas the framework was obviously developed from previous work that had already been done.
Great, thank you.
And then there's just one last question, unless anyone wants to add any more questions to the question panel. And it's the hindsight question. If you were to do this project again, would you use NVivo differently, and if so, how?
I'm not sure if I'm the right person to ask this to, because I think one of my colleagues was the one most of the coding, so she might think differently. I think we learned a lot about how we could use NVivo through this. This was the biggest project we have used NVivo for, and the most complex way we've used it. Before, it's always been really simple, small studies. I think next time we would definitely still use NVivo, and maybe do a lot of the sort of planning for how we were going to use the data that was going into it, because we just had just massive amount of data, and it was just like, where do you actually start? And NVivo helped structure some of that thinking, but maybe we could do some more of that in advance in terms of what output do we want from it, and how might NVivo help us do that more easily, I guess. So I don't know if that answered your question.
Great. There's no further questions.
Could I just add one point of clarification? I missed what you said about whether you were all physically in the same space or were working on doing your NVivo work from different locations and having to connect online.
So there was I think a team of, so 2 people were mainly in kind of managing NVivo itself, but there was a whole group of us, so there's about 5 of us in the analysis team. So what we did is we would come together on a regular basis to discuss it, but then we'd all go off and work on it separately. And then one of my colleagues, she was kind of managing the master file and all the data, but everybody was sort of contributing to it, and so she could bring in and combine the project files together.
Okay, great, thank you. Okay, we're coming to the end of our hour. I would like to thank the 2 presenters for their great talks today, and remind everybody that this is recorded, and we will have the link available on the IIQM website shortly, so that if you want to review some of it, I think some people joined late or had difficulty with audio, everything will be there for you. And I'd also like to thank QSR for arranging this great talk. So thanks very much, everybody.